Hi, everyone. My name is David Berg, and I'm a cardiologist at the Brigham and Women's Hospital. I'm going to be presenting you with a board review practice session. And I started doing this session when I was a chief medical resident, so I promise you that the topics that I'll cover are going to be broader than just cardiology, although there'll certainly be some cardiology included. Let's go ahead and dive in. I have no disclosures. Okay, so case number one. A 23-year-old gentleman with a history of mild asthma presents for evaluation of intermittent dysphagia for solid foods. He denies heartburn. He has not lost weight. He reports that 1 year ago, he underwent an upper endoscopy for removal of pieces of steak. He has taken omeprazole 40 milligrams twice daily for the last 2 months, but his symptoms have persisted. His physical examination is unremarkable. An upper endoscopy reveals circular rings in the mid-esophagus. A biopsy shows a dense eosinophilic infiltrate. Which of the following is the most appropriate next line therapy? A, esophageal dilation. B, oral nifedipine. C, topical swallowed fluticasone. Or D, botulinum toxin or Botox injection into the lower esophageal sphincter. I'll give you a couple seconds to think that one through. So the answer to this question is C. And what this question is about is eosinophilic esophagitis. And so before hopping into the management, I think it's helpful just to review the diagnostic criteria. So there are three key elements to the diagnosis of eosinophilic esophagitis. First, there have to be symptoms of esophageal dysfunction, for example, dysphagia and food impaction as described in this clinical scenario. There has to be a pathologic diagnosis, so a biopsy that shows greater than 15 eosinophils per high-powered field. And then the third supportive piece is that their patients generally have a poor response to high-dose PPI, proton pump inhibitor, or normal pH in the distal esophagus. A couple important things to note is that this diagnosis is more common in men than in women. And first-line therapy is one of two options, either high-dose PPI for 8 weeks, or particularly when that's not effective, topical corticosteroids. So the example that was given in the case was of oral fluticasone, but fluticasone or budesonide are reasonable choices, given for a total of 4 to 8 weeks. Other therapies that are sometimes used are elimination diets or leukotriene antagonists. And it's important to know that dilation is really reserved for fixed strictures that do not respond to medical therapy. Case 2. A 22-year-old woman sustained a compound tibial fracture during a motor vehicle accident requiring surgery. Her hospital course was complicated by a lower extremity DVT, or deep venous thrombosis. She has no personal or family history of PE or DVT, and a hypercoagulable workup is negative. She's not taking any medication. She started on rivaroxaban, 50 milligrams twice daily for 21 days, followed by 20 milligrams once daily. How long should she be anticoagulated? A, 1 month, B, 3 months, C, 12 months, or D, lifelong anticoagulation. And the answer to this case is B, 3 months of anticoagulation. So the key to this question is to identify that the question is asking you to compare provoked versus unprovoked DVTs, for which there's different durations of anticoagulation required. For patients who have provoked DVTs, or DVTs that are occurring in the context, for example, of oral contraceptive use, recent surgery, prolonged immobilization, recent trauma, or pregnancy, the standard recommendation is for 3 months of anticoagulation therapy. And shorter durations of anticoagulation therapy should be avoided. So it's well established that 3 months is important, to no less than that. For patients who have a unprovoked or recurrent DVT, that's when we consider longer term anticoagulation. And so in those scenarios, actually, because of the persistent hypercoagulable state in most patients, the recommendation is for extended or lifelong anticoagulation therapy in those cases. And the specific duration will often depend on a discussion between the patient and the provider. Shown on the right in the picture is a picture of something called phlegmasia ceruleum dolens, and so that's when there's such bad venous outflow obstruction that you can actually end up with lower extremity ischemia, arterial ischemia, because of a functional compartment syndrome. And so in those cases, that's when things like thrombolytics or thrombectomy would be considered. But shy of those kinds of presentations, standard dose anticoagulation is the generally preferred choice. So moving on to case 3. A 64-year-old woman presents for a new primary care visit with complaints of increasing dyspnea and exertion and fatigue. On physical examination, you note that the patient appears pale. She has no jugular venous distension or heart murmurs, and her lungs are clear. Her liver and spleen are not palpable, and she has no lower extremity edema. Her laboratories are notable for a white count of 10,000, a hematocrit of 23, with a microcytic anemia, with an MCV of 65 and an RDW of 20%. And her platelets are greater than 1 million. They're 1,006,000, with an LDH of 158 and a SED rate of 24. What is the most likely cause of the patient's thrombocytosis? Is it A, iron deficiency, B, subacute bacterial endocarditis, C, acute myocardial infarction, D, autoimmune hemolytic anemia, or E, essential thrombocythemia? Give you a couple seconds to think that one through. Okay, so if you guessed A, you got the answer correct. And so this question is getting at the nature of thrombocytosis and whether this is likely to be a primary or a secondary thrombocytosis. Another word for primary is a clonal thrombocytosis, whereas secondary is a reactive process. So just by way of background, primary or clonal thrombocytoses are bone marrow disorders. And in general, those are often associated with vasomotor, thrombotic, or bleeding complications. And in most cases, they're associated with splenomegaly on exam. By contrast, platelet counts can be quite elevated in the context of acute inflammation, infection, chronic illness, or after splenectomy. It's very rare in those cases for there to be any associated vasomotor, thrombotic, or bleeding complications, or for there to be any organomegaly. One of the important distinctions is that the platelet count, or one of the important things to keep in mind, is that the platelet count alone does not dictate whether or not a thrombocytosis is related to a primary or a secondary cause. And the most common cause of secondary thrombocytosis is iron deficiency. So in this case, we were told that the patient had a microcytic anemia. So between the microcytic anemia, that in constellation with a thrombocytosis, that ends up being the most likely scenario. Interestingly, iron deficiency causes thrombocytosis due to stimulation of platelet precursors by EPO. So if remembering that mechanism helps you, that's an important thing to know. All right, moving on to case 4. A 42-year-old gentleman with HIV infection and a CD4 count of 188 presents with new headaches. A CT scan of the head reveals 2 ring-enhancing lesions with mass effect. Which of the following is least likely to be the etiology of this finding? So this is the least likely. A, toxoplasmosis. B, primary CNS lymphoma. C, progressive multifocal leukoencephalopathy, or PMLE. D, tuberculosis. Or E, staphylococcus. A second. So the answer to this question is C. If that's if that's what you guessed, you got it right. And so what this question is getting at is some of the radiographic features of CNS lesions in patients with HIV infection. So when you're considering the differential diagnosis for CNS lesions in patients with HIV, the first question is to ask is, what is the immune status of the host? So if a patient has a normal CD4 count, for example, the patient's on antiretroviral therapy, the differential is going to be quite different. It's going to be more parallel to an immunocompetent, any other immunocompetent host. If a patient is immunocompromised, has a low CD4 count, and typically we're talking about CD4 counts under 200, the next important question to ask yourself is there evidence of mass effect or no mass effect? And typically, patients who have, if there's mass effect, that's also associated with ring enhancement, where there's central necrosis and peripheral ring enhancement. Those types of lesions are typically seen in patients with either toxoplasmosis, CNS lymphoma, or tuberculosis. By contrast, among patients with and where there's no mass effect and there's no ring enhancement, the differential tends to be PML, HIV encephalopathy, or CMV encephalitis. Case 5. A 55-year-old gentleman with hep C cirrhosis presents for follow-up after an upper endoscopy reveals medium-sized esophageal varices. He has no history of GI bleeding. On examination, his blood pressure is 110/55, and he has a pulse of 85 beats per minute. His abdominal examination reveals splenomegaly, and there's no shifting dullness or fluid wave. Which of the following is indicated for primary prophylaxis in this patient? A, norfloxacin, B, nadolol, C, TIPS, transjugular intrahepatic portosystemic shunt, D, both nadolol and variceal banding, or E, isosorbide mononitrate. Give you a second to think about that one. So if you guess B, you got the answer correct. And so this question is getting at what's the management for primary variceal bleeding prophylaxis. So all patients who have a diagnosis of cirrhosis should undergo a screening endoscopy. And if on that screening endoscopy, either medium or large varices are discovered, the patient needs some form of variceal bleeding prophylaxis. The question then relates to whether or not the patient has had a prior esophageal variceal bleed. So if a patient has had a prior variceal bleed, moving on to the left side of the figure, then the patient should be generally treated with both a non-selective beta blocker like nadolol, as well as variceal ligation. In patients who have recurrent variceal bleeding, sometimes, or ongoing active variceal bleeding, sometimes a TIPS procedure is required to stop the bleeding, but that's not used as a prophylactic strategy generally. In this case, our patient has had no prior history of bleeding, so we move to the right side of the figure. And in that case, either treatment either prophylaxis with a non-selective beta blocker like nadolol or variceal ligation are reasonable choices, but it's not necessary to do both. One of the options had been norfloxacin, and it's important that that's prophylaxis for SBP, for spontaneous bacterial peritonitis, but there's no indication in this case that this patient has SBP. Case number 6. A 50-year-old woman with Marfan syndrome presents with substernal chest pain radiating to her back. Physical exam reveals a 2 out of 6 early diastolic murmur, and the following ECG is obtained. Give you a second to look at that. Which diagnostic study would you obtain first? Would you obtain an A, transthoracic echocardiogram, B, a CTA of the chest, C, cardiac catheterization, D, a lung VQ scan, ventilation perfusion scan, or E, a vasodilator SPECT? If you guessed B, CTA of the chest, then you got the right answer. So this question is getting at imaging of acute aortic dissection. And I'm going to go back 2 slides just so you can take a quick look at the ECG. So here we have a patient who's presenting with chest pain, and there's evidence of inferior ST segment elevations with reciprocal depressions in the anterior precordial leads. So in this case, there is concern for an ST segment elevation MI. However, the clinical history of midsternal chest pain, tear midsternal chest pain radiating to the back, raises suspicion for aortic dissection. Some of the other clinical features that might be supportive of aortic dissection, in addition to substernal chest pain and radiation to the back, are the presence of a new diastolic murmur. Important as you're taking the boards to look out for other risk factors that may clue you into this diagnosis. For example, history of connective tissue disease, hypertension, smoking, established atherosclerotic cardiovascular disease, pregnancy, trauma, or a pre-existing aortic aneurysm, some substrate for this to occur in. One of the important things as you're looking for supportive evidence is to recognize that acute aortic dissections can result in ST segment elevation MIs, and the most common pattern is for there to be extension into the to the right coronary cusp, which in right dominant patients will result in an inferior ST segment elevation MI. There are a couple different imaging modalities that are acceptable here, but the most commonly used one is CTA, CTA of the chest and the aorta. It's reasonable to get a TEE, a transesophageal echocardiogram, while those are often harder to obtain. And then MRAs are used in certain circumstances, but again, protocoling those and obtaining those typically take a little bit longer, and so CTA is generally the preferred modality. One of the options was a vasodilator SPECT, which is perfusion imaging that's generally used for myocardial ischemia, so not appropriate in this context. Case number 7. A 58-year-old woman with hypertension who's treated with hydrochlorothiazide and atenolol presents with right lower quadrant abdominal pain. She ends up undergoing an abdominal CT, which reveals a low attenuation homogeneous adrenal mass that measures 2.7 centimeters. Her abdominal pain resolves without intervention after several hours, and she has no further complaints. What should be the first step in your evaluation? A, fine needle biopsy of this adrenal mass. B, magnetic resonance imaging of the abdomen. C, a repeat CT scan. D, plasma and urine hormone evaluation. Or E, surgical exploration and resection. All right, so the correct answer to this question is D, which is hormone evaluation. So this question is getting at the dreaded adrenal incidentaloma. An adrenal incidentaloma is defined as an adrenal mass that's greater than 1 centimeter in size. So in this case, where there's a 2.7 centimeter adrenal mass that's discovered incidentally on abdominal imaging, it qualifies as an adrenal incidentaloma. These actually turn out to be quite prevalent in the general population. So some estimates based on radiologic studies are that it's about 4% of the population have an adrenal incidentaloma. Most of these are non-functional benign adenomas of little or no clinical consequence. But in certain circumstances, they can be cortisol-secreting adenomas, so that's one type of functioning tumor, aldosterenomas, so a functioning adenoma that secretes aldosterone, or a pheochromocytoma. In addition to these functional tumors, there are also malignant tumors that can sometimes that these adrenal incidentaloma can sometimes be, including adrenocortical carcinoma or metastatic lesion. The key issue in the management of these patients is the first step should always be hormonal testing, because it's important to exclude those first 3 options: cortisol-secreting tumors, aldosterenomas, and pheochromocytomas. If the hormonal testing is negative, it's then reasonable to proceed with FNA to evaluate for metastatic disease if a patient has a known primary malignancy. So this would be a situation where they had a known tumor somewhere else, and now you're trying to establish whether there's metastasis. One of the key things is that you should never biopsy or resect without first ruling out a hormonally active tumor. One of the options had been MRI, which can sometimes give you some clues to the etiology, but that does not rule out the functioning that this is a functioning tumor. And so first step is always hormonal testing. Case 8. A 54-year-old woman presents to her PCP with new onset headache. The pain is retroorbital, unilateral on the right side only, and has been progressive over the course of 3 weeks with intermittent responsiveness to acetaminophen. She denies visual changes, fevers, chills, jaw claudication, or weakness. Her exam is normal, including a thorough neurological examination. What is the appropriate next step in her management? Is it A, treatment with oxycodone, B, obtaining a head MRI and MRA, C, amitriptyline therapy, D, empiric sumatriptan therapy, or E, referral to physical therapy? So the answer here is B. It's to obtain imaging. And so what this question is really testing you on is, do you know the indications for when it's important to obtain brain imaging in the workup of patients with headaches? So we often talk about headache warning signs, and a couple of the headache or the key headache warning signs are listed here. So is this the first or worst headache of the patient's life? Is this Are there headaches that are increasing in frequency or increasing in severity? So clearly out of proportion to what have been the patient's historical headaches. Is this a new onset headache occurring after age 50? So recall that the patient in this question stem was aged 54 and there was no prior history of headaches. That in of itself is a warning sign that requires further investigation. Other scenarios, if patient has new onset headaches in the setting of a prior history of cancer or immunodeficiency, that's important to exclude cancer and infection. If the headaches are occurring in the context of mental status changes or meningeal signs, for example, fever, neck stiffness, meningismus. If a patient has focal neurologic deficits in association with their headache, um, then those are all grounds, those are all evidence of headache warning signs and require further investigation. In terms of treatment of migraines, we talk about abortive therapies and prophylactic therapies. Abortive therapies include things like NSAIDs, triptans, and antiemetics. Prophylaxis can be things like amitriptyline, beta blockers, antiepileptics. But all of those are going to be treatments once you've excluded a more ominous diagnosis than a migraine. Um, a couple of other things that came up in the question stem were treatment with opioids and physical therapy. So this, although that was not directly what the question was about, it's important to know that those are generally considered less effective therapies than the pharmacological therapies I just told you about. Question 9. A 31-year-old monogamous woman with no past medical history presents for a routine pap smear. The cytological result is negative for intraepithelial lesion or malignancy. Reflex DNA testing for high-risk human papillomavirus, HPV, is performed and is negative. She has no history of abnormal pap smears. What is the next best step in her management? Is it A, that you would repeat the cytology with HPV co-testing in 1 year? Is it B, that you would repeat cytology and HPV co-testing in 2 years? Is it C, that you would repeat cytology with HPV co-testing in 3 years? D, high-risk HPV testing alone in 3 years, or high-risk HPV testing alone in 5 years? So the answer is E, high-risk HPV testing alone in 5 years. So let's take a moment to review the cervical cancer screening guidelines based on the USPSTF recommendations. So one of the important things to distinguish when you're evaluating women in terms of their cervical cancer risk and their screening approach is whether or not they are above or below the age of 30. So in this question stem, we learned that the patient was 31 years of age. So she falls into a different category than women who are in their 20s. For women who are in their 30s, there are three acceptable treatment strategies. Either cytology, which is a pap smear every 3 years, uh, primary HPV testing alone every 5 years, or the combination of cytology with HPV co-testing every 5 years. All three of those strategies are acceptable. For women who are between the ages of 21 and 29, cytology or a pap smear every 3 years is the approach. As opposed to the HPV co-testing. The strategy of HPV co-testing in this population has limited utility and should generally be avoided since so many women in this category just end up clearing the HPV infection on their own. Case 10. A 56-year-old male from Western Massachusetts presents to his primary care physician with a fever and rash that have been going on for 2 weeks. He has no other symptoms. His Lyme ELISA and Western blot tests are positive. You can see the rash in the picture on the right. What is your next best step in the management of this patient? Is it A, treatment with doxycycline, a single dose of 200 milligrams? B, ceftriaxone, administered 2 grams IV daily for 3 weeks? C, amoxicillin, 500 milligrams TID for 2 weeks. D, doxycycline, 100 milligrams BID for 2 weeks. Or E, azithromycin, 500 milligrams times 1 as a loading dose, followed by 250 milligrams for 4 days. So a Z-pack, essentially. think about that question? All right. So the correct answer to the question is D, treatment with doxycycline for 2 weeks. So for those of you who hail from where I hail from in the Northeast, this may be very familiar territory. For those of you who are not in a Lyme endemic area, this may be less familiar territory. So what this question again is getting at is what's the appropriate treatment of early Lyme disease? And what we learned in this case was that this is a patient who has the classic erythema migrans rash of Lyme disease, which typically appears within 7 to 14 days after the tick detaches. Most of these patients have just one lesion. About a quarter of the patients have multiple lesions, and that represents where the tick had multiple tick bites on the same patient. Um, a couple things important to note is serologic testing is only 40% sensitive. And so it's not required if there is a classic erythema migrans rash. In those situations, even if the serologic testing is positive, you would just treat empirically. And the treatment of choice for early Lyme disease is, in fact, doxycycline for 2 to 3 weeks. It's important to note that it treats other tick-borne diseases as well, specifically anaplasmosis, but it's not appropriate therapy for babesiosis. Um, for patients who are either pregnant or who are children, so pediatric patients, doxycycline is not the appropriate choice. It should either be amoxicillin or cefuroxime. And then if patients have advanced disease, so for example, they have heart block or they have neurologic disease, that's a different treatment than early Lyme disease. And those are the situations where we reach for third generation cephalosporins like ceftriaxone. Case 11. A 68-year-old woman with asthma presents to her PCP with right foot paresthesias, progressive right foot drop, and an erythematous rash over both lower extremities. 5 months prior, she had a productive cough and was found to have patchy infiltrates on chest x-ray, prompting treatment with antibiotics. Her labs are notable for a white count of 9.6 with 58% polys, 9% lymphs, and 30% EOs. Her hematocrit is 36, her platelets are 271. Which of the following diseases is most likely to be the cause of the patient's presentation? Is it A, granulomatosis with polyangiitis, GPA, which was formerly called Wegener's, B, temporal arteritis, or GCA, C, schistosomiasis, D, EGPA, formerly known as Churg-Strauss disease, or E, Hodgkin's disease? So if you guessed D, EGPA, or eosinophilic granulomatosis with polyangiitis, which was formerly called Churg-Strauss disease, you would be correct. EGPA has a classic symptom triad, which includes asthma, sinus disease, and peripheral eosinophilia. A couple clues that might clue you into the diagnosis. So if there's new onset, particularly severe asthma and particularly late onset asthma, that should be a trigger to start thinking about EGPA. When that occurs in the context of mononeuropathy, either mononeuropathy multiplex or a single nerve, or with polyneuropathy, that's also a pretty classic feature for EGPA. The rash in these cases is somewhat variable. So about 60% of patients will initially present with rash, but that's not uniformly present. But paranasal sinus abnormalities are extremely common. So patients with allergic rhinitis, recurrent sinusitis, nasal polyposis, all of those are strongly suggestive of EGPA, particularly in the context of the other findings. Patients with EGPA should have eosinophilia. So that includes patients with either greater than 10% EOs on the differential or greater than 1,500 absolute eosinophil count. There are often radiographic abnormalities notable on the chest x-ray that may be also associated with chest symptoms as well. But often these are migratory or transient pulmonary infiltrates. The diagnosis of EGPA is supported by the finding of a positive p-ANCA or the specific anti-MPO antibodies. And if you were to biopsy these patients, the typical findings are extravascular accumulation of eosinophils or granulomas. This is a granulomatous disease, or eosinophilic pneumonia or small vessel vasculitis. So all of those pathologic features would also be supportive of a diagnosis of EGPA. Case 12. A 19-year-old woman presents with 3 days of vaginal discharge. She is sexually active with one partner. Her last menstrual period was 4 days ago. And when she presents, her exam shows a temp of 99, a blood pressure of 100/60, and a heart rate of 90. Her pelvic exam shows copious mucopurulent discharge from a red, inflamed cervix. She has tenderness on palpation of the cervix, but no adnexal or uterine tenderness. A gonococcal and chlamydia nucleic acid amplification probe returns positive for N-gonorrhea. What is the next management step for this patient? Is it A, administration of ceftriaxone 125 milligrams IM times 1, B, ceftriaxone administration of 250 milligrams IM times 1, C, ceftriaxone 125 milligrams IM times 1, but also azithromycin a gram times 1, D, ceftriaxone 250 milligrams IM times 1, also in combination with the azithromycin 1 gram, or E, doxycycline 100 milligrams twice daily for 7 days. Let's take a closer look at those doses and think about it. Okay. So the answer to this question is D, and just to go back and take a look at those, it's the higher dose of ceftriaxone in combination with the azithromycin. So what this question is getting at is, do you know the updated treatment guidelines for gonococcal infection? And the important thing is that 5 years ago now, the CDC updated its treatment guidelines to require or to recommend co-treatment with both ceftriaxone and azithro for patients with gonococcal infection. Since the last time you took the boards, this was an increase in the dose of ceftriaxone from the 2011 guidelines. The rationale for the increased ceftriaxone dose and the use of dual therapy was increasing reports of clinical treatment failures and as well as some microbiologic data as well. So there were isolates that demonstrated decreased susceptibility to cephalosporins, including increased MICs, cephalosporin-resistant strains. And so the feeling was that treatment with a macrolide in combination with the third generation cephalosporin was important. Just to mention, doxycycline was mentioned as one of the answer choices, but in general, the cephalosporin resistant strains are tetracycline resistant as well, so that's not an appropriate co-therapy. Case 13. A 34-year-old woman is seen in the emergency department with confusion, malaise, and nausea. Her past medical history is notable for allergic rhinitis. Her medications include loratadine and fluticasone. On exam, the patient is alert and oriented to self only. She's noted to have jaundice and bilateral lower extremity petechiae. Her labs are notable for hematocrit of 21, platelet count of 45, and a reticulocyte count of 15%, as well as an LDH of 1500. All of her coagulation parameters are normal. And this is a peripheral smear. I'll give you a couple seconds to take a quick look. Which of the following is the best next step in the management of this patient? Is it A, to perform a direct antiglobulin or a Coombs test? Is it B, to check an ANA? Is it C, to obtain a transthoracic echocardiogram? Or D, to give intravenous immune globulin? Or E, to initiate plasma exchange? And again, that's another picture of her smear in case you didn't get a good look the first time. Okay, so the answer to this question is E, to initiate urgent plasma exchange. So this question is getting at what is the acute management of patients with primary TMA syndromes. TMA stands for thrombotic microangiopathy. And so the smear is key here. So the smear demonstrates supportive evidence of microangiopathy, which is having at least 5 schistocytes per high power field, as well as rare platelets. Really, there's almost no platelets on the smear. The primary thrombotic microangiopathy syndromes include a vast spectrum of disorders, including TTP, HUS, and many others. The supportive clinical features of a thrombotic microangiopathy syndrome include a MAHA, or microangiopathic hemolytic anemia, thrombocytopenia, neurologic abnormalities, and GI symptoms. And then in some circumstances, there's also an associated acute kidney injury. This is a little bit less common with TTP than some of the other TMA syndromes. For TTP, the hallmark is really a low ADAMS T13 activity level. So when the ADAMS T13 activity is less than 10%, that is essentially diagnostic of TTP. However, this test, although it should be sent immediately when TTP is suspected, often doesn't come back for some time, sometimes on the order of days. And time is of the essence with this disease. And so if there's suspicion for TTP, as there is based on the question stem here, early empiric initiation of plasma exchange or PLEX is needed to treat presumptive TTP in order to decrease morbidity and mortality from this disease. Once you get the appropriate testing back, you can then make a decision about whether to continue plasma exchange. Case 14. A 45-year-old man with a history of dyspepsia presents to the office with new dysphagia. He initially developed dyspepsia with occasional heartburn several years ago, and these symptoms responded to omeprazole 20 milligrams daily. 2 years ago, his symptoms recurred, and so his PPI dose was increased to 40 milligrams daily, which again, managed to control his symptoms. But he's now presenting with difficulty swallowing solid foods. What's the next best step in his management? Is it A, to change the PPI to twice daily dosing, so to go to 40 milligrams BID? Is it B, to add a nighttime dose of an H2 blocker on top of the PPI? C, refer for a barium swallow study. D, refer for upper endoscopy. E, treat the patient for a presumed H. pylori infection in this case. And so the answer to this question is D, to refer the patient for upper endoscopy as part of the management of dyspepsia. So what this question is getting at is when is it appropriate to perform an endoscopy in a patient with dyspepsia? And so first, before hopping into those, when we talk about dyspepsia, what we're talking about is a blanket term or generic term for chronic or recurrent upper abdominal pain. The key things, like the headache question that we talked about before, is to identify what are the alarm symptoms that would make us want to exclude cancer. And so those are patients who have a prior family history of upper GI malignancy, if there's associated weight loss, if there's associated GI bleeding or unexplained iron deficiency anemia, if there's progressive dysphagia or odynophagia. So that's the one that's relevant in this case, if the patient's now having trouble swallowing solid food. If a patient has persistent vomiting or a palpable mass or lymphadenopathy, all of those would be indications to obtain an upper endoscopy. If the patient's younger than 60 years and there's no alarm features, in general, what the big thing that you would want to exclude would be H. pylori. So in that case, we test for H. pylori and treat, and also treat them with PPI therapy, like this patient's been treated with in the past. If the patient is either 60 years or old, either 60 years of age or older, or has any of the alarm features that I told you about, then early endoscopy with biopsy for H. pylori is important. It's important to realize that there's a low positive predictive value, but a high negative predictive value for cancer. So if you do not see any cancer on the upper endoscopy, then it is strongly suggested that the patient does not in fact have cancer. Moving on to case 15. A 24-year-old man presents for an annual physical. On exam, he's noted to have a harsh 3 out of 6 systolic crescendo-decrescendo murmur that's best appreciated at the left lower sternal border. The murmur does not radiate to the carotids and is increased with a Valsalva maneuver. A prominent S4 is heard. What is the most likely underlying pathology in this case? Is it A, congenital aortic stenosis, B, Marfan syndrome, C, hypertrophic cardiomyopathy, D, early onset hypertension, or E, rheumatic heart disease? And so the question here is, the correct answer here is C, which is that you're worried about hypertrophic cardiomyopathy. And one of the key things is really differentiating among systolic murmurs so that you're told that this patient has a harsh systolic murmur. And so now you have to think about what is the differential and what maneuvers might you do to try to tease that out. So the major differential here is between hypertrophic cardiomyopathy and aortic stenosis. So already the fact that we're told this is a young patient would make us think a little bit more about HCM rather than aortic stenosis. But the features of HCM murmurs are that they have systolic crescendo-decrescendo murmurs that are related to LV outflow tract obstruction, oftentimes with mitral regurgitation that's related to systolic anterior motion of the mitral valve. And that's what's driving the murmur as opposed to, or the turbulent flow as opposed to something about the valve itself, or the aortic valve itself. Generally, the HCM murmur does not radiate to the carotids, and it's generally increased with Valsalva. And that's because you have less filling of the left ventricle in the setting of Valsalva maneuver. So you have relatively underfilling of the left ventricle, and therefore more collapse of the LV outflow tract, and that's going to tend to increase the murmur of HCM. Important to note that HCM is an autosomal dominant disorder of the cardiac sarcomere and has variable penetrance. And the major reason that's important to suss this out on exam and then also pursue this is because there's an increased risk of sudden cardiac death, and so patients need appropriate risk stratification. So by contrast to the murmur features of HCM, aortic stenosis, while it's also a systolic crescendo-decrescendo murmur, tends to radiate to the carotids, and it's generally decreased with Valsalva. Again, the physiology there is you have relative underfilling of the left ventricle, and so therefore less flow across a stenotic lesion. Less flow across a stenotic lesion translates to a decreased murmur, and so that would be suggestive of AS. The three common causes of aortic stenosis are bicuspid, calcific, and rheumatic heart disease. So in this case, all those features pointed us towards hypertrophic cardiomyopathy. Case 16, a 22-year-old male college football player with no past medical history presents to the emergency room for evaluation of a small abscess on his neck. The collection is IND'd, and the gram stain reveals GPCs, or gram-positive cocci, in clusters. What treatment would you prescribe in this case? Would it be A, oral vancomycin, B, oral dicloxacillin, C, oral trimethoprim sulfamethoxazole Bactrim, D, oral penicillin, or E, intravenous nafcillin? Think about that for a second. So the answer here is C, treatment with trimethoprim sulfamethoxazole. And what this question is getting at is what's the appropriate treatment for community-acquired MRSA? So community-acquired MRSA is the most common organism in skin and soft tissue infections that's seen in the emergency department. And while historically the initial outbreaks that were reported were in patients who are athletes, in military personnel, in IV drug users, and men who have sex with men, the epidemiology has changed. And so this may be something that is different from the last time that you took the boards. And really, we consider community-acquired MRSA in almost anyone. Particularly if there's suggestive clinical features, for example, the development of abscesses. Couple important things in terms of treatment. Community-acquired MRSA is not susceptible to penicillin, so it's not appropriate to treat these patients with penicillin, with dicloxacillin, or nafcillin. But community-acquired pneumonia can be treated with a couple of different oral antibiotic regimens, including clindamycin, trimethoprim sulfamethoxazole, or a long-acting tetracycline, for example, minocycline or doxycycline. And so of the answer choices that provided, the one that fit this was trimethoprim sulfamethoxazole. If a patient has a severe community-acquired MRSA infection, then that is a patient who generally has to be admitted for IV antibiotics. In which case, the first line options are either IV vancomycin or daptomycin. One of the other things that came up was treatment with oral vancomycin. So although we use IV vancomycin to treat MRSA, there's no role for oral vancomycin in the treatment of MRSA. And that's because oral vancomycin stays within the gut, and it's used exclusively to treat patients with C. diff infections. Case 17. A 56-year-old man with heart failure with reduced ejection fraction is admitted with cough, fever, and a right lower lobe infiltrate on chest x-ray. He is diagnosed with community-acquired pneumonia and started on levofloxacin. On hospital day 2, the following rhythm is seen on telemetry, and the patient is found to be unresponsive. So what is the next best management, best step in the management of this patient? Is it A, defibrillation, B, synchronized cardioversion, C, intravenous magnesium administration, D, amiodarone, or E, isoproterenol? So if you guessed A, defibrillation, you're correct. And so what this question is getting at is the management of torsade de pointe, uh, or of torsade de pointe, or polymorphic VT. So torsade de pointe is a polymorphic VT that's specifically occurring in the context of a prolonged QT. And that's distinguished from polymorphic VT that occurs in the setting of a normal QT, which is most often related to acute myocardial ischemia. There are a couple different variants of polymorphic VT occurring in the context of prolonged QT. They can either be congenital, and oftentimes these are associated with long QT syndrome genetic variants. Or in this case, torsade occurred as an acquired condition because of a QT prolonging condition. Those can be drugs that are associated with QT prolongation, for example, fluoroquinolones, macrolides, which are often used to treat pulmonary infections, or antipsychotic drugs as well. Electrolyte abnormalities can precipitate torsade or can lead to QT prolongation that can then precipitate torsade. So, for example, hypokalemia or hypomagnesemia. And then bradyarrhythmias can sometimes lead to torsade, and that's because there's a long RR interval followed by a short RR interval, and that long short sequence leads to inappropriate accommodation of the QT segment. Treatment for unstable VT-VF of any flavor, regardless of what the underlying etiology is, immediate defibrillation. So here we were told that this is an unstable patient, and so that's why the answer here is immediate defibrillation. In addition, some of the specific torsade treatment includes administration of intravenous magnesium. So that can be used to treat and prevent recurrent torsade de pointe. So once the patient is stabilized, they've been defibrillated and stabilized, then it's important to administer magnesium. But that's not going to terminate a hemodynamically unstable torsade. In addition, some of the other adjunctive therapies that we use are isoproterenol or RV pacing. And what we're trying to do is to make the heart go faster so that there's not these long, short sequences, and that tends to shorten the QT interval. And so by preventing bradycardia, you also prevent QT dispersion, early after depolarizations that then precipitate torsade de pointe. Again, like intravenous magnesium, this approach is not appropriate for terminating hemodynamically unstable torsade. Case 18. A 42-year-old alcoholic man with no other past medical history is admitted with nausea and vomiting after recent binge drinking. Lab studies reveal an anion gap metabolic acidosis and urine ketones. His blood glucose is 100. What is the appropriate first step in the management of this patient? Is it A, intravenous insulin administration, B, intravenous steroids, C, intravenous dextrose, D, intravenous normal saline, or E, intravenous folate? So if you guess D, you're correct. Administration of normal saline or crystalloid. And this question, the diagnosis presented in this question is alcoholic ketoacidosis. Alcoholic ketoacidosis is caused by decreased carbohydrate intake, as well accompanied by alcohol-induced inhibition of gluconeogenesis and stimulation of lipolysis, all of which come together to produce a syndrome of alcoholic ketoacidosis, which typically presents with an anion gap metabolic acidosis with demonstration of ketones either in the blood or in the urine, but they occur in an alcoholic patient who does not have diabetes generally. And so there was no evidence to support DKA here as an alternative explanation. The initial treatment of alcoholic ketoacidosis is IV fluid resuscitation. Insulin's not given because the glucose is not elevated, and we're not treating DKA. Dextrose is given, but only after thiamine administration so that we avoid the problem of Wernicke's encephalopathy. And folate repletion is important for malnourished or alcoholic patients, but it's not the most important acute treatment for AKA. Fluids first. Case 19. A 52-year-old man is seen in urgent care after he was found to have 2+ blood on a urinalysis performed as part of a life insurance evaluation. He is a former smoker, but otherwise has no past medical history, no prior chemical exposures, and no family history of cancer. You repeat a urinalysis and examine his urine sediment under a microscope. He has 6 red blood cells per high-powered field, which are normal appearing. What is the most appropriate evaluation? Is it A, to check an IgA level, B, to obtain a CT urogram, C, to refer to nephrology for a renal biopsy, D, to refer to urology for cystoscopy, or E, to obtain a CT urogram and refer for cystoscopy? So the question, the appropriate answer here is E, which is to obtain a CT urogram and refer for cystoscopy. And this question is getting at what's the appropriate evaluation of microscopic hematuria. So microscopic hematuria is defined as having greater than 3 red blood cells per high-powered field on urinalysis. And the key thing is to distinguish whether or not there are dysmorphic red cells present or red blood cell casts that are present. If either of those are present, it suggests a glomerular source of the bleeding, in which case a renal biopsy should be considered. If there are no evidence of dysmorphic reds or no RBC casts, in other words, the red blood cells are normal appearing, as was the case with our patient, then we should suspect a non-glomerular source of bleeding. Most often, this is ureteral bleeding related to nephrolithiasis. But the concerning feature would be bladder bleeding related to bladder cancer in particular, but can sometimes be seen as cystitis as well. If that's the case, the appropriate workup then is both obtaining a CT urogram as well as cystoscopy if a patient is above the age of 35 or they are at risk for bladder cancer. Case 20. A 50-year-old woman presents to the emergency department complaining of a sore throat and concerned that a fish bone is stuck in her throat. She had a URI 3 weeks prior, but is now feeling well. Her vital signs are stable, with a heart rate of 80 and a blood pressure of 126/76. Her anterior neck is tender on exam, and direct laryngoscopy is normal. Her labs are notable for a TSH of 0.03 and a SED rate of 80. What is the most appropriate treatment? Is it A, propylthiouracil or PTU, dosed at 150 milligrams BID, B, atenolol 50 milligrams daily, C, no treatment, and just recheck the thyroid function studies in 4 to 6 weeks, D, radioiodine ablation, ablative therapy, or E, methimazole 10 milligrams TID. So the answer here is C, do nothing. And what we're faced with in this question stem is a patient who is presenting with subacute thyroiditis, and the question pertains to the management of subacute thyroiditis. Generally, subacute thyroiditis presents with pain or tenderness of the thyroid on exam, and that's what distinguishes it from other forms of thyroiditis. Painless thyroiditis is generally an autoimmune process, so that includes Hashimoto's, postpartum thyroiditis, and drug-induced thyroiditis, and those generally result in a chronic hypothyroid state. By contrast, painful subacute thyroiditis often follows a URI, and so that leads to oftentimes there is a period of thyrotoxicosis followed by a period there may or may not be a period of hypothyroidism. So here there was a very low TSH. This was a patient who that reflects the fact that this is a sort of hyperthyroid state. And so in those scenarios, beta blockers may be useful, but only really to treat symptoms or tachycardia. Since this patient was not particularly symptomatic and was not tachycardic, really the appropriate therapy here is just to watch and then to repeat thyroid function test down the line. Radioiodine ablative therapy is really reserved for Graves' disease, toxic multinodular goiter, or for thyroid cancer. Would not be appropriate for subacute thyroiditis. Case 21. A 35-year-old male presents to urgent care with a 2-week history of purulent rhinorrhea and right-sided maxillary sinus pain. His symptoms have persisted despite acetaminophen, fluticasone nasal spray, and saline irrigation. He takes hydrochlorothiazide 25 milligrams daily and amlodipine 5 milligrams daily for hypertension and has no known drug allergies. His exam is notable for a temp of 101.5, copious rhinorrhea, and tenderness with percussion over the maxillary sinuses. His cardiac and pulmonary exams are unremarkable. What is the most appropriate next step in the management of this patient? Is it amoxicillin, dosed 500 milligrams TID for 5 to 7 days? Amoxicillin clavulanic acid or Augmentin, 875 and 125 milligrams twice daily for 5 to 7 days? Higher dose amoxicillin clavulanic acid, 2 grams with 125 milligrams BID for 10 days. D, doxycycline 200 milligrams daily times 5 to 7 days, or E, levofloxacin 500 milligrams daily for 5 to 7 days. So the answer here is B. It's treatment with amoxicillin clavulanic acid. I'll go back and show you the dosing. 875 milligrams of amoxicillin with 125 milligrams of clavulanic acid twice daily for 5 to 7 days. So this is a patient who's presenting with acute bacterial rhinosinusitis. And the clinical features that support that are persistent symptoms of greater than 7 to 10 days with still ongoing severe symptoms. So high fevers, purulent nasal discharge, and facial pain. Oftentimes, the clinical course will be one of improvement followed by worsening. And those are all suggestive that this isn't potentially bacterial superinfection or bacterial infection. Treatment per IDSA guidelines is amoxicillin clavulanic acid is first line with the dosing that we discussed. The high dose amoxicillin clavulanic acid, which is the 2 grams, is reserved for patients with particular risk factors. So age greater than 65, immunocompromised hosts, recent antibiotic use, recent hospitalization, or high prevalence of resistant strep pneumo. In those cases, you would use the higher dose of Augmentin. Important also to note that both doxycycline and levofloxacin can be used for patients who have a penicillin allergy. Okay, so moving on to case 22. A 30-year-old female presents to clinic complaining of bilateral breast pain. She states that the pain is worse toward the end of her cycles and also in the evening. She's had the pain for 3 months and describes it as an aching, diffuse pain. Her exam is notable for a BMI of 28 and pendulous breasts without erythema masses or discharge. She has no lymphadenopathy or skin changes. She's concerned she may have cancer and tells you that her maternal grandmother had breast cancer at age 76. What is the best next step in her management? A, bilateral mammography. B, bilateral breast MRI. C, bilateral breast ultrasound. D, BRCA or BRCA genetic testing. E, reassurance and recommendation for a more supportive bra. So the correct answer here is E, just reassurance and recommendation for a more supportive bra. And the clinical scenario that's described in this question stem is one of cystic mastalgia. Cystic mastalgia is thought to be related to pain in Cooper's ligament and generally occurs from inadequate support of pendulous breasts. And so for a patient like this, where you can recognize that this is cystic mastalgia, you can avoid further investigation, for example, with imaging or BRCA testing. Those would all be considered overly aggressive options. And then our final case here. This is case 23. A 35-year-old man presents to his PCP for a routine physical exam. His only past medical history includes seasonal allergies for which he uses fluticasone nasal spray. He does not smoke cigarettes or drink alcohol. There is no family history of colorectal cancer, although his mother did have 2 documented sessile polyps, one that was greater than 1 centimeter at age 55. Based on that information, when should he undergo his first screening colonoscopy? Should he have it now? Should he have it at age 40? Should he have it at age 45? Or should he have it at age 50? All right, so the correct answer is B. I'll go back and show you those options. So it was now, age 40, or 45, or 50. So this patient should undergo his initial screening colonoscopy at age 40. By way of review for everybody, for colorectal cancer screening, we all know that for average risk patients, colonoscopy should generally begin at 50. There are some scenarios, though, when we screen before the age of 50. And so one of the key things is that if there's a documented history of an advanced adenoma or a serrated lesion in a first-degree relative, then the screening should actually begin at age 40 or 10 years before the diagnosis of the adenomatous polyp in the relative, whichever of those two options come first. So 10 years before the age of 55, which is when it was discovered in his first degree relative, would be 45. So in this case, age 40 comes first. I've underlined it, the word documented, because the guidelines have shifted so that there's really truly demonstration that the family member had an advanced adenoma, so as not to perform unnecessary colorectal cancer screening prematurely in too many patients. And that's the end of our Q&A session. Good luck to all of you on the boards. I hope you enjoyed the session. Thank you very much.